Check, 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 check. Check, check, check.
This is a good trivia question. Figure out who they are. I said, ma'am, Congresswoman, ma'am, listen. Be careful.
Yes. Thank you.
If you need anything, let me know, and I'll give you the attendance then afterwards.
Okay, thank you. check, check, check.
The subcommittee will come to order. Good morning, and thank you all for joining us today to discuss the Department of Veterans Affairs fiscal year 2019 budget submission for medical programs. The President's budget request includes $198.6 billion in total funding for VA, an increase of nearly $12 billion over last fiscal year. It also includes $90 billion in discretionary funding, an increase of more than 8% above last fiscal year. It's a budget request that is robust, and it's one that continues this nation's long tradition of investing in our veterans and in the care, benefits, and services that they earned through their service to us. Most importantly, It's a budget request that is reflective of veterans' voice, as the American Legion will testify momentarily. During today's hearing, I'm interested in learning more about how this budget would set VA up for long-term success and, in doing so, increase productivity, efficiency, access to care, and quality of care across the VA healthcare system. I also want to know more about how this budget would fund and encourage a top-to-bottom review of VA's resources, physical, financial, and human. This committee, led by Chairman Rowe, has been working hard, hand in hand with our Veteran Service Organization partners, over the last year to craft legislation that would institute a VA asset and infrastructure review. I want to reiterate this morning how necessary that effort is, and my intention for it to encompass a review of more than just buildings and property. During the full committee budget hearing 1 month ago, Chairman Rowe and Secretary Shulkin noted that VA's budget has increased by 175% since 2006. In that time frame, overall federal spending increased by just 54% and gross domestic product increased by only 40%. In order for VA to move forward into a fruitful future, we must ensure a clear and accurate understanding of what VA has, what VA needs, and where VA is going. We need to know that our medical facilities are well-staffed and well-equipped to provide modern, high-quality care where our veterans live. We need to know that VA's relationship with community partners are strong and able to respond quickly to meet needs when and where VA can't. And we need to know what VA's significant and growing financial resources are, being used to their highest purpose and never squandered, wasted, or abused. Absent that, we cannot assure veterans that their needs will be met today, next week, or next year, not to mention 10 or 20 years from now. And we also cannot assure American taxpayers that their hard-earned dollars are being used by VA appropriately, wisely, and well. I'm grateful to our witnesses from VA and from our Veteran Service Organization partners for being here this morning to discuss the President's budget request, and will now yield to Ranking Member Brownlee for any opening statement that she may have.
Thank you, Mr. Chairman. I certainly would like to take this opportunity to, welcome our distinguished VSO stakeholders here today. Your insight is always and continues to be invaluable. And Dr. Clancy, I appreciate you and your team being here with us today as well. I look forward to hearing from you on how VHA intends to continue to meet veterans' health care needs with this budget request. However, it would be unreasonable for me to ignore the current state of affairs at the District of Columbia's VA Medical Center, a facility that for all intents and purposes should be considered a crown jewel of VA facilities. A little over a week ago, VA's Office of Inspector General issued 40 recommendations that would not only improve the operations at the DC hospital, but provided lessons learned for medical facilities nationwide. While the IG did not explicitly state the issues at the DC VA were systemic in nature, history shows that issues surrounding leadership failure point in that direction. My fears were further confirmed when VA placed VA medical centers in VISN 1, 5, and 22 under VA Central Office receivership. Dr. Clancy, your experience implementing significant changes throughout VHA following the Phoenix waitlist crisis makes you uniquely positioned to ensure VA quickly corrects course in these 3 VISNs. I would urge you to ensure that the lessons learned from the Phoenix crisis and any relevant subsequent events are applied in VISNs 1, 5, and 22. I hope VA is committed to implementing lasting change that can be effectively applied to VA medical systems nationwide. I also ask VA to remain transparent during this process so that I and my colleagues here on the committee can continue to both oversee and support your progress. Dr. Clancy, I'm also concerned that the political infighting within VA Central Office has diverted resources and attention from what really matters, the delivery of benefits and health care healthcare services to veterans. Every employee at VA should be focused on what is best for veterans, not what is best for their careers or for the White House, but for the 9 million veterans currently enrolled in the VA's healthcare system. Perhaps this infighting is limited to one particular office or a handful of employees, but it is unnecessarily distracting and, in my opinion, is unprofessional. We can see that within your fiscal 19 budget request, VHA intends to vastly improve the delivery of health care by accomplishing many significant goals. Members of this committee on both sides of the aisle want VA to succeed in achieving each of these goals. I'm hopeful that today's conversation will result in a better understanding of how VHA's budget request will support the accomplishment of these incredibly important goals. Goals that I strongly support, like the expansion of mental health services, continued support of women veterans, and the development of IT infrastructure capable of supporting the 21st century high-performing VHA our veterans deserve. To each of our witnesses, I am thankful for your participation and look forward to hearing your comments. Thank you, Mr. Chairman, and I yield back the balance of my time.
Well, thank you, Ms. Brownlee. So joining us this morning on our first and only panel, our first, Adrienne Attizato, the Deputy National Legislative Director for the Disabled American Veterans, Sarah Dean, the Associate Legislative Director for the Government Relations Department for the Paralyzed Veterans of America, Patrick Murray, the Associate Director of the National Legislative Service for the Veterans of Foreign Wars of the United States, Matthew Schuman, the Director of the National Legislative Division for the American Legion, and Dr. Carolyn Clancy, Executive in Charge of the Veterans Health Administration for the U.S. Department of Veterans Affairs, who is accompanied by Rachel Mitchell, Deputy Chief Financial Officer for the Veterans Health Administration. I want to thank you all for being here this morning. Mr. Attizato, we will begin with you, and you're now recognized for 5 minutes.
Chairman Wenstrup, Ranking Member Brownlee, members of the subcommittee. First, I'd like to thank you for allowing us to testify along with our partner at arms with American Legion and, of course, Executive in Charge, Dr. Clancy, on this panel to talk about VA's budget request for fiscal year 19 and 20. I first do need to start out by having to recognize, I think, the elephant in the room, which is VA's current shortfall funding that it's operating in now for nearly close to half this fiscal year. When we're looking at the budget that has been provided and the budget that has been requested, we're looking at a $3 billion shortfall, which is a significant amount of money considering VA is under tremendous pressure even this fiscal year to meet increased demands. I think that we have to urge Congress very strongly to address not only that shortfall for today's needs, but also because it will affect future estimates and projections. And starting out at a low baseline will clearly affect future performance. As part of the independent budget, DAV, with our partners, Paralyzed Veterans of America and Veterans of Foreign Wars, we're certainly pleased to present our budget recommendations for 2019. I think at the offset, the committee should be aware that our recommendation uses a baseline that is currently what the Congress is contemplating and hopefully will be passing next week to fund the Department of Veterans Affairs. We have to do this because using any other baseline will set VA's 2019 recommendations well below what we estimate the need will be. So for 2019 for medical programs, the IB recommends $82.6 billion. This amount includes $53.7 billion for medical services, $14.8 billion for medical community care, $6.8 billion for medical support and compliance, and $7.3 billion for medical facilities. Now, we do recommend an additional $829 million for medical and prosthetics research. This amount includes $65 million for the Million Veteran Program. As this committee knows, there's a little over 600 million veterans who have volunteered to participate in the Million Veteran Program. It is the most future-looking research project that VA has going, and we believe that $65 million, or if Congress is so inclined to provide more, will help VA finally reap the benefits of this program. They need to do much deeper sequencing than is currently being done to be able to leverage and tailor its programs to the specific needs that veterans have. We also believe that Congress should provide VA $1.6 billion for its electronic health record modernization. I believe this was the amount that Secretary Shulkin had initially requested, and we're thankful that this budget from the President and the Department of Veterans Affairs includes recognition of that need as modernizing a critical aspect of VA in its delivery of services to veterans. I would be remiss, Mr. Chairman, if we didn't talk about a couple of things, a couple of legislative proposals in the President's budget, which we have specific comments on. The first thing I would like to bring to your attention is their request to finally pay for medical foster home, which is a far less costly alternative to nursing home care, and one that many veterans are flocking to because it is still set in a community setting. This authority allows VA to pay for that care instead of veterans having to pay out of pocket. And it would allow VA to pay for those veterans who otherwise VA would have to pay for nursing home anyway. And we think this would save taxpayer money. In fact, VA estimates the first year of saving about $12 million, going all the way up to $90 million a few years after that. We do oppose, however, a legislative proposal that would offset the current practice of offsetting veterans' co-payments when VA receives reimbursements from Veterans Health Plan. We think this is a disingenuous way of supplementing appropriations to provide veterans medical care that they have earned. The second one that we would have to oppose, Mr. Chairman, is the punitive enforcement of making veterans have to pay over $8 million worth of medical care if somehow VA is not able to recover reimbursements from their health plans. We think, again, that is a misguided attempt to supplement its needed medical care resources on the backs of veterans. I see my time has run out, Mr. Chairman. I will end my testimony at this point. Be happy to speak more about our recommendations and any of the contents in our testimony. Thank you.
Thank you. Ms. Dean, you're now recognized for 5 minutes.
Chairman Weinstrup, Ranking Member Brownlee, and members of the subcommittee, as one of the co-authors of the independent budget, Paralyzed Veterans of America is pleased to be here today. I will focus my comments to a few areas of concern. In September of 2016, Congress authorized appropriations through fiscal year 18 to provide the reproductive service in vitro fertilization for veterans with catastrophic disabilities or injuries that precluded their ability to have children. VA projected through the 2 years that this service would affect no less than 500 veterans and their spouses and cost no more than $20 million. As of January of this year, some 500 consults for IVF have been made. And we thank those of the subcommittee for ensuring that these veterans now have the chance at a family that otherwise would have been denied them because of their service. However, these procedures are not directly funded, and therefore the independent budget recommends $20 million to cover the costs through fiscal year 2020. Regarding women veterans, the medical services appropriation should be supplemented with $500 million for women's health care programs, in addition to those already included in the 2018 baseline. These funds would allow VHA to hire and train the necessary 1,000 women health providers that are needed to meet the increasing demand for gender-specific care. These funds would also enable the facilities to address privacy and safety issues for women patients and further the work of cultural transformation throughout the agency to ensure women are welcomed at VA, are free from harassment, and are recognized for their service. This is also needed for VA to continue the work it's been doing to improve mental health services, particularly in order to combat suicide and substance abuse disorders. As women veterans are the fastest growing cohort of patients, VA must have the resources to properly provide the appropriate care. To that aim, the subcommittee must also conduct the necessary oversight to ensure that that care is the quality they deserve. In addition to an increasing women veteran population, VA must also be resourced and ready to accommodate a majority aging population. The demand for and utilization of long-term care services and home and community-based services has increased consistently and will continue to in the decades to come. As such, the IB recommends a modest increase of $82 million for fiscal year 19. This reflects the demand for long-term care services in 2017, particularly home and community-based care, as well as the increase in use in long and short-term stay nursing home care. This increase would help balance home care services with the institutional settings, a strategy currently pursued at the state level. VA must be properly provisioned and ready to meet this impending wave of aging veterans. And so in that vein, a new addition to this year's independent budget recommendation is the necessary funding to implement the eligibility expansion of VA's caregiver program to severely injured veterans of all eras. The funding level is based on the CBO's estimate for the expansion preparation costs. That includes increasing staff and IT fixes. And for that initial phase, we recommend $11 million for fiscal year 19. We appreciate the attention this subcommittee and the full committee has given to caregivers. This issue is a high, if not the highest priority for most of our members. And we hope to see change happen soon. As you heard from many of us last month, this issue is time sensitive. Pre-9/11 caregivers are in need of support as quickly as possible, and we hope that Congress will enable VA to provide those services. Their well-being quite literally depends on it. So, Mr. Chairman, I thank you for the opportunity to speak here today, and I'm happy to answer any questions.
Mr. Murray, you're now recognized for 5 minutes.
Chairman Wenstrup, Ranking Member Brownlee, members of the subcommittee, on behalf of the men and women of veterans of foreign wars, the United States and its auxiliary, and our partners in the independent budget, I thank you for the opportunity to provide our remarks on the infrastructure portion of the budget. While this year's numbers are significantly higher than the previous years, we still feel it doesn't quite hit the mark. For more than 100 years, the government's solution to provide health care for our military veterans has been to build, manage, and maintain a network of hospitals across this nation. This model allows VA to deliver care at thousands of facilities, but it's left it with ownership of more than 6,000 buildings and 38,000 acres, many of which are past their building life cycle. Many of these facilities need to be replaced, some need to be disposed of, others need to be expanded, and all of them need to be maintained. The process to manage this network of facilities is a Strategic Capital Infrastructure Plan, or SCIP. The SCIP identifies VA's current and projected gaps in access, utilization, condition, and safety. Then it lists them in order based on the gap's priority. In VA's FY 2019 budget submission, the 10-year full implementation plan to close these gaps is estimated to cost $53 to $65 billion, including $9 to $11 billion in activation costs alone. Congress and VA need to realign the SCIP process to allow VA to enter into public-private partnerships and sharing agreements, both federal and private, to right-size VA's footprint. It must continue to fund the projects it currently has partially funded and begin the advanced planning and design of those projects it knows will need to fund through the traditional appropriations process. VA's SCIP program clearly identifies the current and projected 10-year gaps in delivery of health care. What is missing is a long-term strategy to effectively close these gaps in the most veteran-centric and cost-effective way. This must include a strategic plan for removing vacant or underutilized space so VA can invest those funds used to maintain these buildings into facilities that can provide direct care for veterans. Facilities will need to be replaced, improved, and reduced over the years, and the methods used to decide when and how to move forward with these projects must be comprehensive. VA can no longer afford to build a new facility and with only a few years have a need to expand the facility because they did not properly forecast the need. Nor should VA feel compelled to maintain a facility that is so underutilized that it's becoming cost prohibitive. As VA works to close these gaps in utilization, VA and Congress must make it a priority to maintain what we have, finish what's been started, and chart a long-term plan to effectively close future gaps. Repeating the sins of the past, such as the Denver Replacement Medical Facility, must never happen again. And VA needs to move ahead in the 21st century, always looking to find ways to build more effectively and efficiently. Finally, outside the budget analysis, the VFW has specific best practice suggestions that could cut time and money from future construction projects by implementing some new innovative ways to course correct some of the mistakes of the past and align their practices with private sector builders. Thank you for the opportunity to testify today before the subcommittee, and I look forward to answering any questions you might have.
Thank you very much, Mr. Schuman. You're now recognized for 5 minutes.
Making a promise is easy. Honoring the promises you made, particularly in the heated political climate we find ourselves in, is more difficult. Chairman Winstrup, Ranking Member Brownlee, distinguished members of the subcommittee, on behalf of Denise H. Rohan, National Commander of the American Legion, and our 2 million members, we thank you for the opportunity to present our position on President Trump's proposed budget for the Department of Veterans Affairs. The American Legion appreciates the President following through with the promises he made on the campaign trail to take care of those who have served the United States in uniform. At a time when most federal agencies are experiencing a decrease in their respective budgets, the VA will hopefully, with assistance from this critical committee, receive a much-needed increase. Our members tell us they prefer to receive their medical care at VA. When an overwhelming force of veterans are all saying the same thing, it is vital that we listen. The President's proposed budget is reflective of veterans' voices and should encourage this Congress to invest in the largest integrated medical system, not only in the United States, but the world. Acknowledging my time before you is short, I will focus on a few critical topics. The conversation surrounding community care is at an all-time high. The need to finally streamline multiple programs into one effective system is vital, especially as current funding may run dry in May. Streamlining the many programs into one is cost-effective, efficient, and most importantly, it's common sense. Following through with the promises he made, President Trump's budget requests funding to ensure veterans receive the best care possible, be it at the VA or in their community. That said, in order for that to happen, Congress must take action to join and modify the programs for the benefit of all veterans utilizing the VA Community Care Program. Additionally, the President's budget echoes Secretary Shulkin's desire to expand mental health access for those with other than honorable discharges, which falls in line with the executive order President Trump signed compelling the DoD, VA, and the Department of Homeland Security to ensure all new veterans receive at least 1 year of mental health care post-military service. Continuing on with the focus of health care, the President's proposed budget not only calls for funding to be allocated, but also requests the funding to be placed in a separate account for VA to obtain the same electronic health record system that the DoD is deploying. Like streamlining community care, restructuring VA's EHR to be the same as the DoD is also common sense and will aid veterans by having one seamless record that will follow them from service to veteran status. Since his time in Congress and on this committee, Chairman Rowe, like many of you, have called for VA to have a simple, effective, and integrated system with the DoD, and will help support this. With help from this committee, it can finally happen. Moving on to a topic that is near and dear to my heart is the eradication of homeless veterans in this nation. The American Legion was beyond pleased in 2009 when then VA Secretary Shinseki laid out a comprehensive plan to eradicate veteran homelessness by 2015. Through General Shinseki's efforts, veteran homelessness saw over a 40% decrease, which was an amazing feat by anyone's standards. That said, at any given point now, there are roughly 40,000 homeless veterans on the streets of America, and that is not acceptable by the American Legion, and I imagine it's also not acceptable by this committee. The President's proposed budget calls to sustain funding levels for the SSVF program, a program that essentially is the center spoked wheel and aids multiple nonprofits at ending homelessness within the veteran community. The American Legion appreciates the President's desire to maintain the level of funding, but highly encourages this committee to make SSVF program permanent, along with increasing the funding for this critical program, which could send a clear message that this committee and Congress wants to end the horrific plague within the veteran community. Lastly, Mr. Chairman, while reviewing the President's proposed budget, we notice an attempt to reduce the promised benefits of some veterans to provide funding for others. The American Legion has long opposed the rounding down of the cost of living adjustment and urges this committee to fight the attempt to rob Peter to pay Paul. We understand that $12 is not a lot of money to some, but to others it is. We understand that some veterans have proudly declared that they would happily give it up to help other veterans, and that only speaks to the character of those this committee and the American Legion aims to help. However, the American Legion, which celebrates its 99th birthday today, has spent the last 99 years advocating and fighting so veterans do not have to shed their own benefits for the sake of helping out their brothers and sisters in arms. In closing, Mr. Chairman, the American Legion appreciates the work this committee and your staff does in the name of truly helping those who have served this nation. Further, we are thankful for the leadership from you and Ranking Member Brownlee to review the President's proposed budget and for engaging the American Legion on these important and critical issues. With that, Mr. Chairman and Ranking Member Brownlee and members of the committee, I'm happy to answer any questions you may have, and thank you very much.
Thank you, Dr. Clancy. You're now recognized for 5 minutes.
Thank you. Good morning, Chairman Wenstrup, Ranking Member Brownlee, members of the subcommittee, and thank you for the opportunity to be here today. Your commitment to and leadership on behalf of our nation's veterans is unwavering and inspiring. And I want to thank the VSOs for their continued commitment and advocacy. And as you noted today, I'm accompanied by the Deputy Chief Finance Officer, Rachel Mitchell. This budget request for 19 is strong and allows VHA to continue on the path towards improving timeliness and quality of care, ensuring greater access to care, as well as increasing investments in our foundational services. It's our duty to ensure the necessary resources, clarity, and tools are available in order to provide care to veterans, and this budget request fulfills that obligation. The budget includes $8.6 billion for mental health services, an increase of $468 million, or 5.8% increase above the 2018 current estimate. This increase enables about 162,000 more outpatient mental health visits in 19 and directs $190 million for suicide prevention outreach. As you know, we have a nationwide epidemic for the entire country, which disproportionately impacts veterans, and that is suicide, which is why suicide prevention is one of Secretary Shulkin's top priorities. VHA recognizes that veterans are at increased risk, and we've implemented a national suicide prevention strategy to address this crisis. It's based on a public health approach that's ongoing, utilizing universal strategies while recognizing that suicide prevention requires ready access to high-quality mental health services. So that means we have programs that address the risk for suicide directly and, very importantly, starting far earlier in the trajectory. We also know VHA can't do this alone. Of the 20 veterans who suicide each day, 14 are not enrolled in our system. So when I was speaking at a conference yesterday, I think the Surgeon General was tweeting, "Find the 14," because that's what we rely on our partners to help us with. We know that the 6 who are enrolled in and get mental health care from VHA actually do better than those who are not. And this nationwide community approach that we need will help us solve some of the upstream risks veterans face, such as loss of belonging, meaningful employment, and engagement with family, friends, and communities. The budget also enables us to effectively implement the President's executive order that supports transitioning military members with mental health services during that first critical year. And at this moment, I just have to salute our VSO partners on this. They have been all over this with us, and so I wanted to say thank you. This joint action plan was developed by the Departments of Defense, Homeland Security, and VA, submitted to the White House on March 9th. Another big problem that we have in VA and frankly in the nation is management of chronic pain. And at the same time, we know the risks to patients of excessive use of opioids. We have made impressive strides working with our veterans to rely less on opioids and use non-pharmacologic treatments such as acupuncture and other alternatives, but we're not done yet. As we continue to reduce excessive reliance on opiate medication and respond to the requirements of the CARA legislation, we're expanding pain management research in 2019 in 2 areas. One is testing and implementing complementary and integrative approaches to treating chronic pain. And in a second, longer-term initiative, we're working on other drug models and current drugs in the market to test their efficacy for treating pain. You may have seen a VA research study published just last week comparing 1-year use of opioids with nonsteroidal anti-inflammatory drugs, which you might know as Advil or Aleve. And actually, at 1 year, the people who are not on opioids had better outcomes. So I might ask to submit that for the record. Another study being developed under the Learning Healthcare Initiative is being launched that will evaluate the impact of implementing a new tool to identify veterans at high risk of adverse effects from their opiate medication. As a couple of my partners here have acknowledged, we have too many veterans sleeping on the streets at night instead of in their own bed in their own home. In 19, we will be investing $1.75 billion in programs to assist homeless veterans and prevent at-risk veterans from becoming homeless. Our initiative develops strategies for identifying and engaging homeless veterans, and researchers also work to assure that homeless veterans receive proper housing, a full range of physical and mental health care, and other relevant services. And they're using existing data to identify and engage veterans who are currently homeless and to develop strategies to identify and intervene as early as possible. As the nation's only health research program focused exclusively on veterans' needs, VA research continues to play a vital role in the care and rehabilitation of our men and women who have served in uniform. Building on more than 90 years of discovery and innovation, our research has a proud track record of transforming VA healthcare by bringing new evidence-based treatments and technologies into everyday clinical care. The 19 budget includes $727 million for development of innovative and cutting-edge medical research for veterans, their families, and the nation. Advances in treatment and medical technologies have significantly reduced the impact of certain disabilities on the lives of many veterans. And we have a full spectrum of research from very, very basic science to the cutting-edge Million Veteran Program, rehabilitation medicine, and so forth. Finally, we are also focusing on women's health, one of our fastest growing cohorts of veterans, by adding almost $29 million in fiscal year 19, an increase of nearly 6% over 18. The number of women using VHA services has more than doubled since 2006 to 2016. And in order to address the growing number of women veterans, we're strategically enhancing services and access for women veterans. Together, we're working to address all of these critical health issues that affect so many of our veterans. We've made a great deal of progress with your support, and there's still a lot more to do. This budget request is a step toward that continued progress, and throughout all of healthcare, we know that the best systems know that providing care that's timely and consistently high quality is a team sport. Mr. Chairman, I look forward to working with you and the committee on doing what's right for veterans and to your questions.
Well, I have to say I'm pretty impressed with everyone today, because everyone was easily under 5 minutes, and we don't often see that, so I appreciate it, so that we can spend the time with our questions and getting some answers. Before I start asking some questions, I do want to make a couple comments. I do appreciate what you're doing for pain management in the VA. You know, I operated on extremities, and you'd think that breaking bones and putting hardware in would be extremely painful, but if you manage it correctly, it doesn't have to be. My patients hardly ever used opioids for the very reasons you're talking about. The use of steroids and anti-inflammatories after surgery, local anesthetic blocks. We need to continue to produce best practices in pain management that avoid opioids, and that's not just in the VA, obviously, but across the country. So I appreciate the work that's being done there. Mr. Murray, you talked about closing the gaps. We need to fill the gaps. That's really what we have to do is fill gaps, and I know that's what you intend to mean there, and I appreciate that. And we need to eliminate dead space and fill the gaps that we need to fill. I just was in Puerto Rico. We did a VA hearing there over the weekend, and you talk about an interesting situation that they have there. The VA in Puerto Rico, their penetration of those eligible to use VA is 72% when it's about 36 across the United States. So those eligible to use VA that do use VA is about 72%. It's a very high number. During the disaster that occurred down there, they kept their lights on. They were open 24/7 taking care of people. They were the main caregiver on that island compared to anyone else. It was very moving to see. And I do want to compliment what I was able to find out from the VSOs that we met with while we were down there. When this disaster took place, you had very high-risk veterans in their homes, if they were even in their homes, by the way, if they even had a roof, some on CPAP machines and things like that that require electricity. And they went out, they gave of their time and treasure to voluntarily go and find high-risk veterans to make sure that they were okay, to make sure that they were getting what they needed, to make sure they could get them a generator so they could keep their CPAP machine running. My hat's off to those veterans that were out there looking out for their other veterans during that time. So I thank you all for being here today. Now on to questions, if I may. I'll go with that. And Dr. Clancy, we know that there's a shortage of providers. There's a shortage of providers across the country, but in the VA, particularly mental health, primary care, and certain specialties, the VA Health Professions Scholarship Program has not provided any scholarships for physicians or dentists in the past 5 years. Will your budget commit some funds to achieve this purpose?
This budget for 19 gives a much bigger increase to the education and debt reduction program. There's been quite a bit of study, Mr. Chairman, on is it more effective to give people scholarships at day zero or to pay back their loans in a very meaningful way later? And in terms of retention rates, I believe that most programs have found that it is actually more effective to do the latter, which is the program that we have. So we're very, very grateful for the support, and we'll be using those funds to target, in particular, providers in the mission-critical occupations.
So you're finding that's a better route to take as far
Yes.
as retaining? It'd be curious to see some of the numbers that you have on that and how you're
Sure.
filling some of the positions that we need. And in that same vein, the budget request proposes hiring almost 6,000 additional full-time employees. Can you provide the subcommittee with a breakdown of the positions that these new employees would fill?
Yes, I'd need to take that for the record, but would be happy to do that.
I appreciate that. I'd like to, we'll probably have a few rounds here today, but I would like to proceed, and Ms. Brownlee, I yield to you.
Thank you, Mr. Chairman. I thank you all for your testimony, and I just wanted to bring up two issues that I think are pretty simple and straightforward and easily achievable in this budget. One is that Ms. Dean brought up in terms of IVF. This is a new program that was established, that's been ongoing, but yet the funding's not there in the budget, and I just think that we need to be clear that this is going to be an ongoing program for our veterans who can't have children because of their service to our country, and it's just critically important that we do that. I don't think anybody disagrees with it. That's why I think it's like a simple, straightforward thing that we can be done. The other thing is, as it relates particularly to women, is understanding that there is a $29 million increase around support for our women veterans, I think, Dr. Clancy, that you said. And that's great. I think you said it was a 5% increase, but you also said that the increase of women veterans has doubled. So
Over 10 years.
over 10 years.
Yeah.
But, I think we need to, look at that number and try to really determine what the impacts and improvements will be with that kind of investment, and where we still need to go, I think, in terms of investment around women's health. The main issue for me, sort of on the macro level, overall looking at this issue, and Dr. Clancy, we discussed this in my office yesterday, is the fact of this particular budget proposal takes all of the healthcare delivery accounts, if you will, and merges them, sort of all into one. So, that the whole issue, the issue that we continue to talk about in this committee is our investment in the VA and its infrastructure, and our investment into a community care program. So I want to, understand why this is, and as I expressed to you in my office yesterday, it's a big concern for me because I think we need to account for how these resources are being spent, and from my perspective, I'm looking for a more equitable distribution of those funds to increase healthcare delivery for our veterans across the country. So I worry that if we combine all of this into one fund, how are we going to make sure where the resources are going? I know you mentioned, well, we're worried about running out of money too early for community care, and this gives us a little bit more flexibility and fungibility with funds, but on the other hand, I'm concerned about, shifting funds fully one way and not the other. So if you could comment on that.
So thank you, and thank you very much for your support for women's health and the other issues that you mentioned. I think it is easy and direct to say, because it is absolutely true, that the Secretary and I share a very, very strong commitment to making our system as strong as possible. At the same time, we recognize that on the ground, particularly in areas where there's competition for particular types of providers, that may not necessarily be a national case, or it may be, or it just may be a very idiosyncratic issue for that market. If a provider leaves, for example, and we have appointments stacked up for that provider, but that person has moved on to another job, or maybe we asked them to leave for some very good reason, then we want to hire as quickly as possible. We're not at a place yet where we can hire that quickly. And more to the point, I think running this healthcare system like a business, you would want our directors to be making a strategic decision: are we going to make or buy? So, for example, in one of our facilities a few years ago, a couple of gastroenterologists left, and their biggest need for gastroenterology happened to be colon cancer screening. So they actually did a pretty good assessment of what was the capacity in the community and decided that it was actually to the government and the veterans' advantage to buy those services in the community. I take your point loud and clear, with concerns about the appropriate balance between VHA and our use of community care as we transition to becoming a high-performing network. The point I would emphasize is that what we're hoping for is flexibility at the local level, so that our directors are making the right decisions rather than saying which way is easiest in terms of needing to go through layers of approval, but that flexibility needs to come with oversight so that we could report to you. And I know that you expressed some frustration that
I'm
we
concerned
haven't
about
been
the oversight
excelled.
piece of it.
Yeah.
I understand, you know, at some level, the ability to be flexible to meet the needs in a community that's going to be different from another community across the country. I get that, but I'm very much worried about the accountability piece of it. My time has run out, but if we have another round of questions, I want to ask the VSOs to comment on this particular issue.
great.
With that, I yield back.
Mr. Bilirakis, you're now recognized.
Thank
for
you.
5 minutes.
Thank you, Doctor. I appreciate it very much. Dr. Clancy, you mentioned that on the mental health services, I really appreciate the President's budget increasing the mental health services by $468 million. Specifically, how much will be spent with regard to the executive order on mental health services for the post one-year transition period? And then if you could elaborate a little bit on the transition period, the executive order, I would really appreciate that.
Sure, and let me just say, starting with the executive order first, that that whole plan is we're just getting some feedback and working through that from the White House, but we'll very much look forward to sharing that with you. And really, as it happened, I had my monthly breakfast with VSOs the morning that this was going to be announced. The actual date was a bit of a work in progress till about a day or two earlier. And when I shared that information, everyone was out of their seats saying, we're in, we have got to be in, because we've got people on basis, or we've got people providing services to veterans who can be part of this solution. I mean, it was really amazing, and since then they have very much been very active partners. Our plan, Congressman, is to invest $500 million over the next 2 years in implementing this executive order. Now, that includes more mental health care services. In some cases, it includes hiring more suicide prevention coordinators. It will include some investments in partnerships, and as well as our whole health initiative. I mean, what we want to have a safety net for transitioning service members for that year, because we know it's a year of higher risk. At the same time, we don't necessarily want to convey the message that by definition you're broken because you are transitioning out of military service. So the whole health model is a model that focuses on the importance of the mind-body connection, alternatives to dealing with stress and coping with life issues. And actually, the initial step for that in implementing the executive order will be a series of orientation sessions. It also includes a very strong focus on peer supports, which many veterans find to be very, very helpful. So happy to give you more details as we build that out, but we do have a very robust plan, and as soon as we're finished dealing with the feedback, we'll look forward to sharing that with you.
So veterans will be involved, the stakeholders will be involved in that as well.
Absolutely, and they have been phenomenal.
Okay,
And we'll be testing it at all times. I had a lovely conversation with the chairman about this, who thinks that actually this needs to start way before the time of transition. And
I agree with that.
I'm totally good with that. And I think this collaboration gives us the space to raise all those issues, but we'll look forward to sharing with you the whole plan.
Please
But
do.
I think of that year as both no wrong door, but also no wrong time.
Very good. I have one more question, Mr. Chairman. The written statement from the independent budget alleges, for Dr. Clancy again, that VA research for post-deployment mental health conditions, gender-specific care, prosthetic care, Gulf War illness, toxic exposure, telehealth, and caregiver support, quote, remain critically underfunded, according to the independent budget, underfunded by the VA. Do you agree with this statement, Doctor?
So having run a research agency, not at VA, but part of HHS for a lot of years, first of all, anyone who says we need more money for research, I'm about to say that's wonderful. That said, I recognize, particularly with the investment that we've made in the Million Veteran Program, that we're constantly looking at what is the best strategy for making those investments and how do we set priorities. I think we get a huge return on investment, both by virtue of how much we get per grant in terms of productivity, but also because of our direct proximity to the delivery system where we can translate those findings into practice and improve care for veterans.
Thank you very much, and I'll give back the rest of my time. Thanks.
Mr. Takano, you're now recognized for 5 minutes.
Thank you, Mr. Chairman. I would like to ask some of the VSOs if they have any thoughts or concerns regarding VA's recruiting and retention efforts or initiatives. What more can be done to address the ongoing challenges related to recruiting and retaining top talent at the VHA?
Sir, one of the things that we view as critical is keeping the Public Service Forgiveness Loan Program. Currently, right now, in the PROSPER Act, the Higher Education Authorization Act, there's a plan to remove that. We think that that's a critical tool for VA to use to recruit and retain the best and the brightest.
Congressman Takano, I appreciate that question. Thank you so much for that. I think one of the things that VA needs, at least something that Congress can do to help VA, is actually help pay these folks better. When we're talking about pay increases, I think they've been hurting for a few years now. So if we could start with who's there and help them, feel like they're being recognized for the hard work that they do day in, day out, I think that will go a long way. Move along to the investment that VA is requesting. It's a pretty small percentage considering the amount of vacancies that they have. Granted that there will always be a certain amount of vacancies, but I think the delta there is a little bit too high for us to have confidence that the number of folks that they're going to hire is actually going to meet the needs of the over 6 million veterans that come to VA every year.
Great, thank you.
And Congressman, I'll echo, I'll echo the same sentiments that has been shared here. I'll also add, this comes to no surprise that, there are over 40,000 vacancies at VA, and the problem is that weight of the job that's not being done by those 40,000 people is added to the other people. We need to ensure that those 40,000 vacancies are filled with quality people in a much faster process, in a much faster way, to ensure that the workload is not divided between everyone else.
I agree with the sentiments of my colleagues. I would only add that regarding pay is considering also that the majority of these providers are providing care for people with a high level of need that involves more physical risk, but also the burnout is that much faster. So taking into account the toil that they're in and the level of work that they're doing when considering pay.
Right, thank you. Dr. Clancy, in the FY19 budget request, I noticed that the VA has advanced the number of new GME positions created under the VA CAA to 774 positions. When do you anticipate filling the other 726 spots?
First of all, that was just a phenomenal opportunity. For those of you who remember from the initial choice legislation, we were given the opportunity to create 1,500 new residency slots. I believe that we're looking at a couple of hundred additional ones over the next few years. The reason we have been a bit slower than I think many had hoped was that the legislation also specified that we should be recruiting providers in primary care in underserved areas and in rural communities and so forth, so we invested a couple of years, which I think was exactly the right thing to do, and we did in broad consultation with the academic teaching community in building the necessary infrastructure at some of the rural facilities that we have that didn't necessarily have it. This is necessary to make sure that students and residents get a good experience, but also, quite frankly, to comply with accreditation requirements from external regulators.
So I realize you had these challenges, and I'm pleased that we've allocate additional resources. Are you confident you're going to be able to utilize the rest of these spots that we've authorized? We work so hard to do.
Absolutely. Absolutely. And one reason that gives me huge confidence and optimism is there are more and more osteopathic schools, and their leadership was just meeting with us, with me and the secretary last week. And frankly, they're producing a much higher proportion of primary care providers, which I think is terrific. But huge growth in that community as well as in the nation's allopathic medical schools.
Well, of course, I'm hopeful that we can try to continue to address the supply of doctors as well as nurses and other practitioners, but especially our physicians and in these underserved areas.
Yes.
And I hope we can continue to work together to help districts like mine and Ms. Custer's and all of the rural states that we have represented on this committee.
No, we would love that. And, you know, to be honest, it creates a new level of excitement and enthusiasm at some of these facilities as well, who've been missing out because they don't have the standard academic affiliates.
Well, thank you. I appreciate that. Mr. Chairman, I yield.
Ms. Custer, you're now recognized for 5 minutes.
Thank you very much, and thank you to my colleague for the shout-out about academic affiliates. We're working on that right now with Manchester, New Hampshire VA, so thank you for all your help on that. A couple of quick questions about the situation in Manchester. For my colleagues, we have a task force now that's trying to look into the future for better access to healthcare services for our New Hampshire veterans. But I am troubled by two developments that I want to bring to your attention. One is that, unfortunately, the president's budget is not encouraging. Manchester, New Hampshire has only one project ranked in the top 50 of the department's strategic capital improvement plan, despite the serious issues that have been laid out in the Boston Globe and that the Secretary and Dr. Clancy are well aware of. The desperate need for primary care translated to an expansion project ranking number 181 on the priority list. So I do want to bring that to your attention and work with you going forward for a commitment on prioritizing projects and the urgency of getting care to our veterans. The second issue has to do with the maintenance budget, and I'm very troubled to read that an additional $4 billion of non-recurring maintenance funding provided by Congress as part of the budget balance agreement is going to be taken back and used for other purposes, and yet we have dozens of Manchester projects as non-recurring maintenance that were listed as future potential projects, and I just want some clarification. If not now, then we'll take it offline, but I'm concerned it's an old facility, as there are old facilities all across the country, and maintenance is critical. The third issue I do want to get direction on, because I'm very troubled by this. There's been part of the VA initiative in developing the Vision 2020 task force was to investigate the needs, which is a good place to start. There's an assessment that's been done, though, that has a glaring error that I want to bring to your attention. It references several times a CBOC in St. Johnsbury, Vermont, that does not exist. And so this whole methodology is called into question because the market assessment used a facility that doesn't exist and talks about expanding that facility, et cetera. So I'm concerned because obviously that calls into question the whole study. So those are the issues related to Manchester. If you can respond, feel free. If not, I'll keep going and we'll take it offline.
Yes, so just on the last, we will fix that error and also have our people take another look at that entire assessment. It was our belief in establishing this task force, and frankly, with your help and many others, we got phenomenal healthcare leaders outside of VA, as well as VSOs and others. The State Director for Veterans Affairs serves as the co-chair. We wanted this to have the conclusions be the conclusion of the task force, not what we were directing. At the same time, if the inputs were wrong, then we need to fix those right away.
And I do want to say I appreciate the collaboration with the community leaders. What my number one concern is that the outcomes from the task force have credibility with our veteran community, with our VSOs, and with our general public. At this point, we have heightened awareness for everyone about the future of the Manchester VA and providing health care to our veterans. So I appreciate your follow-up on that. And I'll just close by saying I was very pleased to hear your testimony about the VA research on the opioid epidemic, and I think it's very promising. Veterans were first in. I'm hoping they'll be first out of the opioid epidemic, and New Hampshire is very hard hit. But what you laid out for research on expanding alternatives for pain management, expanding alternative drug options. I definitely want to look at the research you talked about anti-inflammatories. I think that's critical. And identifying veterans at high risk of opioid addiction. These are all holes in our understanding, and I think once again the VA could lead the country in helping us to solve a critical public health emergency. So thank you for that, and I yield back.
Well, thank you. That is clearly our goal. Just very quickly, we will follow up with you offline about the maintenance and infrastructure issues. I am very, very proud to say that in terms of veterans who are on opioids chronically, new starts, veterans who are started on that path have been reduced by 90%. Which is really beginning to change the equation. That said, we are not achieving the results that we've seen by simply telling people time's up. We are working very closely in partnership with veterans, so I wanted people to be very clear about that.
All right. Dr. Clancy, we hear different numbers on the vacancy rate, and I don't know if you have a particular point in time, a date where you can say when we last checked, on January 1st of 2018, this was our vacancy rate, and maybe that's something you'd have to come back with me on, but I would like to know if you have some kind of data that, and maybe provide us with an accounting of every vacancy by position, job title, et cetera.
I think a productive conversation would be a follow-up offline, and happy to do that or on the record. I will make a couple of points. One is that the department has just recently established, about 4 months ago, a new office of, it was supposed to be called Manpower. I asked for a different name, so I don't know the official name. But the point is that there would be position management across the entire department, of which VHA would be the largest part. We've not had that before. The walk-around number I would use for vacancies is 36,000, which if you look at turnover in healthcare and turnover within our system, sounds about right. That doesn't mean that there are 36,000 empty chairs today, but some are in transition to being filled and so forth. All that said, I think you are all aware that until this year, our HR system required us to more or less send an email to all the facilities to say, how many openings do you have? Because HR had a separate database at each facility. We are now constructing a centralized database in which I know requires a lot of cleanup, which is why it's taking time. So I'm confident that in the next few months, we will have numbers that I would feel very comfortable with. Right now, they're all ballpark.
Yeah, and periodically getting those numbers would certainly be something to look at, and I realize the exact numbers will change daily.
Yes.
And the exact number of positions will change daily, but if we can start to look at some patterns here, and that would be helpful. I also, as we see medicine changing, and we've talked about that, VA assets over the years, we're just like everyone else. It was more hospital-based, inpatient beds and this and that, and we've obviously seen medicine change dramatically, that there are fewer overnight stays and shorter stays within the hospital, more outpatient-type surgery. So where are we in reviewing and maybe realigning some of our assets, like other hospital systems have, to where you have a low census inpatient facility, converting that to outpatient clinics and surgery centers and maybe less than 24-hour stay, that type of thing?
So we're looking at that issue very closely from a couple of different lenses. One is the department and administration's overall focus on modernization, so that each VISN will be doing a market assessment of their markets. That has been slowed down a bit by a contract dispute or protest, but we're not going to be stopping there. It just may take us a little longer to get to the same end goal. I think we're taking a special look as well at our rural facilities, some of which are quite vital in their communities, but the average daily census is pretty low. So we're trying to take a very good look at that to figure out what is the right thing to do. For some patients, that's life-saving to have that stop, even if they end up getting transferred elsewhere. On the other hand, if you've got an average daily census of 5 or 6, you have to be very concerned about quality and safety issues and so forth, but happy to follow up with you on that.
I appreciate that. And Ms. Brownlee, you're now recognized.
Thank you, Mr. Chairman. I just, again, wanted to follow up now with the VSOs on my question to Dr. Clancy in terms of, in this budget proposal, the sort of the merging of all the different healthcare delivery accounts into one and zeroing others out. Do you have any concerns? Anybody can speak to it, but do people have concerns about that?
Well, thank you for that question, Congressman Brownlee. I can appreciate facilities wanting to have the flexibility to do with as they see is required at the local level with the monies that they receive, and I'm pretty sure that community care outside of choice funds is actually all within the flexibility that facilities need to use it in. I think the request to merge the two accounts, the community care account and the future of choice, I think, as well as the regular medical, discretionary medical services. The concern that we have is the ability to conduct oversight in aggregate. I'm all for letting local facilities use the funds that they are provided the way they need it to meet the needs locally, but and for oversight purposes, I don't see why it would be so much trouble to allow us in aggregate in a higher level to look at the performance of VA in providing care in VA as well as in the community.
Anybody else? Or does that represent everybody else's perspective?
I think exactly what he said, we share those sentiments. I will sort of hit the ball out of the park in terms of oversight. That's exactly what this committee is designed to do, and I think it will continue to need to do that. I think streamlining will be, as I said already, effective, and sort of streamlining and try to prevent waste. I think doing this will probably be a good idea, but ensuring this committee exercises its constitutional right of oversight is vital.
Well, thank you for that. And I did, Dr. Clancy knows this, in our meeting yesterday, I talked about, exactly this piece in terms of, transparency, accountability, oversight piece of it. And honestly, my sort of lack of confidence at this particular point in time that VA would provide those deliverables, to the committee in a timely way so that we really know kind of on a quarterly or monthly basis kind of the direction and where things are sort of going, so that we if we need to, we can and sort of reassess. But we're going to just have to wrestle with that, I think, as time goes on.
If I could make one point briefly.
Sure.
We do have one model that works this way, and this is how we allocate medication funding. So there is a central medication pharmacy benefit management program and a central warehouse which gets, higher and higher scores every year in terms of customer satisfaction and so forth. But in terms of purchasing medications, pharmaceuticals at the facility level, they all have an account they can draw on, and that has worked very, very well. What I don't know, but we could certainly find out, is how long it took them to get to that level of reliability, but we'd be happy to follow up with you on that, just as a model.
Very good. So, Dr. Clancy, also, I know that in February, the Secretary received 3 names from the Commission that's tasked with finding viable candidates for the position of Undersecretary of VHA. Do you know if the Secretary submitted any of these candidates for review and potential nomination from the White House?
He mentioned them in a meeting, but that is as much as I know. I believe the Commission met and interviewed a variety of candidates in late January or right at the very beginning of February. Would be happy to follow up with you on that.
Thank you. And just one last question. I concur with my colleague, Mr. Takano, on the issues that he was raising about so many unfilled positions across the VA. I see that as a critical problem, and I do see these sort of vacancies and IT systems across the VA as sort of foundational pieces that we're not going to move forward on a lot of the objectives that we want to achieve, and we spend a lot of time talking about new programs and new goals and so forth, but we have to get back down to some of the foundational issues, which is filling these positions and having sort of state-of-the-art IT systems across the VA. Just in terms of one very important IT system, if you could, Dr. Clancy, kind of provide us with a status update on where we are in terms of Cerner and where that stands. My understanding is that the Secretary was supposed to appear at a Healthcare Information and Management Systems Society conference in Las Vegas, and he was going to publicly announce the award of the Electronic Health Record Management project to Cerner, but that didn't occur. So if you could update us.
He did appear and made some other announcements, which I think will be also very important. But we are closing in on signing this contract. We have one more round of technical review, and we have actually brought in some very, very credible and highly recognized experts from the private sector, and really focused on, are we getting interoperability right? Because not only with the Department of Defense, but within our own system and also with our partners in the community, that is vital to making sure that information flows seamlessly in terms of providing veterans great care. The announcement the Secretary did make was to say that we are opening up our system so that innovators can actually develop apps for the public, for veterans, and there's no entry barrier. So if some startup company has got great ideas for how to do that, they'll be able to do that. And he also announced that 11 other large health systems have made the same commitment, and Cerner will not charge us a transaction fee for doing that. So I think that is going to be a big game changer in electronic records, and looking forward to celebrating with you when it's all signed.
So thank you for that. And I just to get back to Cerner for one moment, and I agree interoperability is critically important. When do you think this is going to get nailed down?
I'm told in the very near future. I was just checking with her.
Is that 2 months, 3 months, a year, 10
I would
days?
guess 1 month, but we'll get you a definitive or the best estimate we can give. We're actually anxious to get moving because we've had people working on this for close to a year now in terms of doing the pre-planning, learning everything that the Department of Defense did, and frankly, learning about what maybe they wish they did differently and so forth. So those folks are very impatient.
Thank you, and I yield back.
I just have one more quick question. We have veterans that have non-service connected conditions that they want to get treated at the VA, and they use their private insurance to do that. My understanding is the collection rate based on billings is only about 36%. Where are we with improving, garnishing that revenue from their insurance if they choose to use the VA, which is a compliment to the VA that they want to do that?
Yes, we have a new leader in community care who comes from the private health insurance industry and actually has vast experience in this. So I'd like to take that offline, but bring it back to you. One of the other issues that we run into, of course, is I don't think we are as good as we should be. It's just, this is how we're supposed to do it in terms of asking veterans. So I think the conversation that goes on a lot is, do you have your insurance card? And someone says no, and we say, okay. I mean, that's kind of the end of the conversation. And frankly, I think that we need to educate our veterans more, that this is not a special punishment that we're administering, that this is actually what the statute requires.
Gotcha. Well, listen, I want to thank everybody for being here today, and if there's no further questions, the panel is now excused, and I ask unanimous consent that all members have 5 legislative days to revise and extend the remarks and include extraneous material. Without objection, so ordered. The hearing is now adjourned.